Good afternoon, everyone. We are going to get started in just a minute. We'll wait about 30 more seconds to let a few more folks join us, and then we will get started. Thank you. Okay, good afternoon. Welcome to today's webinar, Trauma-Informed Transformation for Local Health Departments. We are excited to have you all join us from all over the state. My name is Laura Altman, and I am the director of the Illinois ACEs Response Collaborative here at Health and Medicine Research Policy Group. We are excited to be joined today by Dr. Audrey Stillerman, Marlita White, and Dr. Sandra Martell, who will be providing us with an overview of the science of ACEs, the process of becoming trauma-informed, and then we will hear about the exciting work that's happening both here in Chicago at the Department of Public Health and in Winnebago County. So before we get started, just a few very quick housekeeping things. We will have about 10 minutes of Q&A at the end of the webinar, so please submit your questions in the question box throughout. We will facilitate a Q&A at the end. After the webinar, you will also receive an email that will have a short evaluation survey, ways to participate with the Illinois ACEs Response Collaborative, including a link to our website. We will include a recording of the webinar, and we will also have a link for registration for our next webinar, which is on June 20th, which I will tell you about in a little bit. So as I mentioned, I'm from Health and Medicine. We work to improve the health of all people in Illinois by promoting health equity. We are based in Chicago and do our work statewide. Health and Medicine is the lead convener of the Illinois ACEs Response Collaborative, which is a multidisciplinary group that utilizes the science of ACEs and childhood trauma in an effort to create critical transformation to policy and practice aligned with current research. We work to develop education, policies, and responses to assist those who have experienced a high level of adversity, while simultaneously developing strategies to reduce the frequency and impact of ACEs, as well as prevent their transmission to the next generation. So we have a lot, if you're interested in learning more after this webinar about ACEs and trauma-informed care, we have a lot of resources on our website. The link is here, and we will also send it out afterwards. So this webinar is part of an initiative that we have with health departments across the state of Illinois. We are excited to be able to offer technical assistance for those health departments that want to begin or advance the journey of becoming trauma-informed. This is the first webinar in a series. The next one is on June 20th at 10 a.m., and it's about the buffering role of community resilience against ACEs. It will be led by Dr. Suzette Fromm-Reed, who is a community psychologist and an associate professor of National Louis University. And we've heard that the role of community is one that you all are interested in, so we encourage you to participate and attend the webinar if you can. We will have other webinars that will be scheduled focusing on things like the role of trauma in the opioid epidemic, making the case for investment in trauma-informed care, home visiting, and more. And thanks to those of you who filled out our survey and let us know the topics that you are interested in. We will also be offering in-person training a couple times around the state in the late summer that will be a more in-depth overview of trauma and ACEs. And we're making a number of resources and handouts specifically for health departments about ACEs and trauma that you can use with your staff and with your clients. And lastly, for a small number of health departments that are really interested in pushing this work forward more quickly, we can offer intensive support. And so you can reach out to me if you're interested in doing that. So that's it for my intro. I'm going to turn it over now to Dr. Audrey Stillerman. And here she is I'll start with her bio, and then Audrey, I will give you control of the mouse so that you can move your slides. An advocate for Chicago's most vulnerable residents, Dr. Stillerman is a board-certified integrative family physician, Associate Director of Medical Affairs for the University of Illinois Office of Community Engagement and Neighborhood Health Partnerships, Clinical Assistant Professor in the UIC Department of Family Medicine, member of the Illinois ACE Response Collaborative, and co-founder of the Center for the Collaborative Study of Trauma, Health Equity, and Neurobiology, also known as the Venn Center. Since learning about the profound impact of ACEs, Dr. Stillerman has made it her mission to share this critical information with colleagues, patients, students, and community members. We're very lucky to have her today to talk to us more about ACEs and trauma. And so I will give you control in just a second. Okay. Audrey, you may have to unmute yourself. Oh, Audrey, if you're talking, we can't hear you right now. Oops, sorry about that, folks. Okay,
Laura, can you hear us?
Oh, now we can hear you, yeah.
Great. Okay. So sorry. We were playing with the phone, and we shouldn't have been doing that. Thank you for that introduction, Laura, and also hi to everybody on the webinar. We really appreciate you joining. So I want to get started. We're going to do an overview. For some of you, this will be review, and others of you, it'll be new information, but I think it'll be really great for us to just get kind of on the same page with definitions and some science background. So first, the definitions that I want to review today are adversity, which is any experience that is challenging or difficult. The word trauma, we're going to actually use the SAMHSA definition, which is an experience or set of experiences that either threatens us or harms us physically and emotionally, or does the same to somebody who's close to us or somebody whose experience we're witnessing. That these experiences overwhelm our ability to cope, and that they have an impact, a negative impact on our functioning and well-being. And then I'd like to just define the term neuroplasticity, which is our brain's ability to change. And we're really fortunate that our brain is able to change over the course of our whole lives. And then finally, the word resilience, which is our ability to bounce back. And the thing that I want to emphasize about resilience is that although every human being is born with the potential to be resilient, we are not born resilient. We need loving support and scaffolding in order to learn the skills of resilience. So if somebody is not resilient, it is not their fault. They just haven't had the right care and structure yet. There we go. Okay. So I want to just spend a little bit of time talking about the ACE study, which is 20 years old this year. The first paper was published in 1998. And the Adverse Childhood Experiences, or ACE study, occurred during the mid-90s and was a collaboration between a large HMO in California, Kaiser Permanente, and the Center for Disease Control. And this study surveyed over 17,000 participants about their experiences in childhood of abuse, neglect, and household challenges, as well as their health and well-being, physical health, mental health, and social well-being in adulthood. The participants were mostly white and Hispanic. They were employed. The majority of them had some college education. They were all insured, and the average age was about 57, with the age range of about 19 to 90. The results of this study really rocked the public health and health world. It was things that I think people had talked about on and off actually for about a century and a half, but not with this same direct connection to health and well-being across the lifespan. So these were the results of the ACE study. There we go. First, what Dr. Felitti and Anda, the co-authors, found is that ACEs are extremely common, that in this sample, about 2/3 of adults had had at least one of these experiences. A little more than a quarter had 3 or more, and about 5% had 6 or more. They also learned that these experiences tended to cluster together, so that if you had one of them, you were highly likely to have more than one. They found that the accumulation of ACEs matters. So in other words, the more that you had, the more likely that you were to have health and social issues. And so that there was a graded relationship, a dose-response relationship between the number of these experiences and health outcomes. So that these experiences actually were a good proxy for childhood toxic stress. And then in fact, many people say, experts say, that ACEs are the most powerful known influence and predictor of health. So sorry, you guys. Hang on one second. I tried. Okay, here we go. I'm having a little trouble with the laptop. I'm so sorry. Now I'm going the wrong way. Okay, here we go. So there have been many studies that have picked up on the results of the Adverse Childhood Experiences study, and what these studies have shown is that ACEs can have lasting effects on physical health, so things like obesity, diabetes, STDs, heart disease, on mental health like depression, hallucinations, on health compromising behaviors such as smoking, alcoholism, drug use, and high-risk sexual behavior, and also on life potential, so on graduation rates, academic achievement, and lost time from work. And in fact, ACEs have been associated with over 40 outcomes. Of note is that of the 10 leading causes of death in the country, about 6 of them can be traced back to adverse childhood experiences. Some subsequent work has also demonstrated that not only are these experiences that happen in the household important, but also experiences that happen in the community, like violence, unemployment, poor schools, experiences that happen in the structures of our society, like racism, misogyny, heterosexism, and even experiences that happen across time, so things like slavery, genocide, war, forced displacement. All of these experiences also seem to have a dose-response relationship in terms of outcomes across the lifespan, and there's often intersectionality among all of these experiences. I just want to take a minute to take a look at some things that we've had public health campaigns around over the years. The blue bars are things that we have existing public health campaigns around, so like, banning public smoking to prevent secondhand smoke, or, texting and driving, reducing lead exposure, et cetera. And the red bars actually are associations between adverse childhood experiences and outcomes. And all of these indicators related to adverse childhood experiences actually have stronger, higher odds ratios than those indicators around which we've built public health campaigns. So I think it pushes us a little bit to really think seriously about how we design our work to really take into account adverse childhood experiences. We are pushed to ask the question, how do the experiences that happen outside our body get into our bodies and cause health problems? And so we're just going to spend a few minutes talking about brain development, attachment, and physiologic regulation. So on the left-hand side of your screen, you'll see a little diagram of the brain, and I'm just going to take a minute to talk about normal brain development. So the brain develops from the bottom up, from the survival brain to the thinking brain, and that begins in utero and actually goes all the way up to about age 25 or 30 before our brain is really finished. And that early development between the in utero period and age 4 is a very important time because that's when our brain gets organized, and it actually gets organized in response to our experiences. So if we're in a situation with our caregiver, who's the biggest part of our experience in those years, and that person is okay enough and able to have an attuned and connected relationship with us, then our brain develops optimally according to our genetic potential. But if that person is stressed for any reason, doesn't have their basic needs met, is working too many jobs, is living in a war zone, has just had a big loss, etc., that has an impact on the health and development of our brain. Now, that 0 to 4 period is the most important period for organization, but really all throughout the time that our brains are growing and changing, our experiences have an impact. And that is as a result of neuroplasticity. The brain takes the information it gets from the outside world, and it actually sends signals to the rest of the body and the organs through the autonomic nervous system. And that's the diagram that you see on the right-hand side. And so once the brain has processed the information, it sends those signals which create change in terms of the body's attempt to maintain balance. And so if the information that the brain receives is not threatening in any way, that information gets up to the thinking brain, and we're able to use that information to do things like make judgments and create things, etc. And the rest of our body is in kind of a calm, alert state. However, if that information reaches the brainstem and it appears to be threatening, it never makes its way up to the thinking brain, and the brainstem sends information down to the rest of the body to be prepared to survive. If, excuse me, if the brainstem is activated too often without having the modulating effect of the cortex, because information that's presented is threatening over and over and over again, our stress response system gets sensitized, and instead of kind of going along this nice balanced green curve that's in the middle, which is a balance between our activating part of our nervous system and our quieting part of our nervous system, we can get stuck on off or stuck on, and these are symptoms of undischarged traumatic distress. So if we're stuck on, we may experience anxiety, panic, hyperactivity, irritability, chronic pain, etc. If we're stuck on off, we may be low energy, have depression, have trouble with digestion, all of the things that the balance really helps us to do. And sometimes it's not that we're stuck in one place or the other, it's that we're actually swinging wildly from one extreme to the other because our stress response system can never really get back to that nice green, quiet, balanced baseline. So in summary, this is the research consensus, which is a combination of epidemiology and neurobiology work. And so the idea is that the pathway to chronic illness begins actually when trauma overwhelms our protective factors and causes neurodysregulation. And this neurodysregulation can cause inflammation and abnormal endocrine signaling. And the outcomes are all the things that you see listed on the right. So physical and psychological disease, health inequity, behavioral challenges, poor academics, contact with law enforcement, and more. And so what this science really shows us is that trauma, overwhelming protective factors, is really both the root of the problems that we're interested in preventing and having an effect on, and also an opportunity for prevention and the most effective treatment. So this is just a little list of what trauma means for our staff too, because of course our staff is part of the general population as well. But we often have increased health problems among our staff, increased worker turnover, problems with tardiness and absenteeism, and just not functioning at full capacity for staff, both in terms of the trauma that they've experienced before they were our employees, but also the trauma that they may be exposed to in serving our clients. So I want to just turn our view to SAMHSA'S concept of a trauma-informed approach. SAMHSA uses the 4 R's, so realizing how common trauma is, recognizing how it affects all the individuals involved in our organizations, responding by putting this knowledge into practice, and resisting re-traumatization of clients as well as staff. And I've actually added a 5th R, which is building resilience. So to be a trauma-informed organization, we would build our program around these 5 R's. This is actually getting even a little bit more granular, but the Center for Healthcare Strategies has put together a roadmap for trauma-informed care, and it looks at activities at both the organizational and the clinical level. And so these are entry points for us to begin our trauma-informed journey. Finally, I want to share with you that becoming trauma-informed is actually a process over time. This doesn't happen in an instant, and that there are points along the spectrum that kind of help us assess where we are, and they really go from the initial trauma awareness all the way to becoming trauma-informed and trauma-specific. So I'm going to end there, and I'm going to turn it over to Marlita to talk a little bit about what we're doing at the Chicago Department of Public Health.
Thank you so much. I'm going to actually jump in. This is Laura again. I'm going to introduce you officially, Marlita, and thank you, Dr. Stillerman, for that overview. It was really helpful, and to learn more about, I think, ACEs, and then also an overview of what the trauma-informed process can be. We're going to turn now to hear the examples from Chicago and Winnebago County, which can really give us some concrete ideas of how a health department can lead this effort and go about making change. So first up is Marlita White. Marlita is a licensed clinical social worker and is a seasoned crisis responder with experience in conflict mediation, psycho-spiritual bereavement counseling, and peace circle facilitation. She is a frequent trainer on childhood trauma, teen dating violence prevention, community engagement, and childhood exposure to violence prevention. Her violence prevention work spans managing federal demonstration projects, collaborating on program evaluation and action research, strategic planning, and multi-year, multi-site program implementation efforts. And she is currently the director for the Chicago Department of Public Health's Office of Violence Prevention and Behavioral Health, where her portfolio includes violence, mental health support, and substance use prevention and response. She currently co-leads various trauma-informed, transformation-focused initiatives, and we are lucky to have her talk about her work. So thanks so much.
So good morning or good afternoon, everyone. I think I'll start by saying the ways that we entered into the trauma-informed transformation process is really threefold. Within our Department of Public Health, my office obviously focuses on violence prevention and behavioral health, and for more than maybe about 12 or 14 or so years, we've been in the childhood exposure to violence and child trauma space. And so we're really happy to see the burgeoning interest and opportunities to encourage more systematic transformation. But also within Chicago's infrastructure, we have a Health and All Policy Task Force, which looks across city departments and creates opportunities to understand the the impacts for the public's health with respect to any kind of large-scale decision, whether that's out of transportation or aviation or sanitation, so not just within the health sector related departments. And then lastly, the Chicago Department of Public Health Health and All Policy, the Healthy Chicago 2.0 policy agenda. This document focuses on three primary kind of leverage points. One, we're creating opportunities for city partners, meaning community-based organizations, city departments, other municipal partners who do business in Chicago, and obviously other health sector partners to really work together and try to understand and create a pathway forward where health equity improvements are really at the center of the goal. Also looking to leverage data, much more data than we've used in the past, pressing down into communities, inviting community leaders to comment and respond to surveys and so forth, but also maximizing epidemiological data as well. And then really basing the the Healthy Chicago policy agenda on root causes. One of those things that we had an opportunity to do with the Healthy Chicago process was to really think critically about how do we improve health outcomes. So looking absolutely at promotion of behavioral health, how do we get into communities and try to understand what are the barriers to health-seeking behaviors and what kinds of messaging need to be modified and or promoted differently. Strengthening child and adolescent health, promoting and preventing the chronic disease agendas, and then also reducing the burden of infectious disease. And then, of course, we see violence prevention being a part of those kind of underlying priorities. Within Healthy Chicago 2.0, and that document is available online if you Google Healthy Chicago 2.0, we have four goals where we're talking about reducing or decreasing victimization, strengthening families, and reducing mass incarceration. But what we have also as the fourth goal is to support the process of Chicago being a trauma-informed organization or trauma-informed city, and then that the health department would itself take on the task of trying to become a trauma-informed organization to lead that way. For us, as Audrey already mentioned, we really are trying to take a systematic approach to becoming trauma-informed, trying to understand what that might mean for the health department, but then also as we build out our tools and resources to try to understand what and anticipate the needs of our sister departments, and then as well working with other community organizations and initiatives to try to build into the resources that other city groups and community-facing organizations will utilize in their own transformation efforts. In terms of the why Chicago and why now, I think is probably, if you're on this webinar, you probably think that all cities should be trauma-informed, or at least we hope you do. So, of course, we know that a part of our charge is to help people understand that being trauma-informed means that we need to respond to the trauma, as Audrey mentioned, in the lives of not just the people that we serve, but in the people that we work shoulder to shoulder with. So how do we get beyond just this notion that only the behavioral health centers need to understand this work? We have to be able to communicate to all of our partners, regardless if they're doing behavioral health or if they're responding to lead abatement calls, that really being able to respond compassionately is the goal that we're moving toward, and that the majority of the people that we serve are very vulnerable and very likely have these unresolved trauma narratives that are at the core of some of their needs that bring them into our service centers, but also it definitely is interacting with the ways that they present for services. And because we are working with people who as staff members and coworkers also have their own trauma narratives, that those things are showing up in the ways that we deal with our human relations issues within the workplace. One moment, I think we're having just a little technical.
Click on the bottom icon on the bottom, the little blue star.
Okay.
You should still have control.
Okay, I think we're back. So you all did a great job of holding on. This was a little practice on meditation. So in terms of adverse childhood experiences, we've already heard about the ACE study, and I think what we'll just leave this in terms of the graphic is that a part of the work that we're doing within the transformation efforts within the health department and the city departments is helping to make the case that ACEs matter, not just for the people that we serve, but also it is a part of the ways that we are managing our workforce. So you see here absenteeism, financial concerns, and serious job-related issues. And then these graphics just talk about that graded response that Audrey already talked about in terms of ACE exposures with respect to suicidal attempts and the likelihood of being raped. In terms of the CDPH model, we're just really talking about how do we create the space that is safe enough and organized and structured enough and has the political support within the department to begin to talk about some of those concerns that are very, in some cases, very obvious, but not often really deconstructed and actually addressed. So what we have at the department, we have a trauma-focused transformation team. That team has been broken out into subgroups, and this is just a little bit about the various subcommittees that we have. I will say that these subcommittees are staffed by some of the same people, so we don't have 95 people on our various subcommittees, but nevertheless, our work does kind of detail out. We have an evaluation team that's responsible for overseeing the development of our logic model so that we know that as we start to look toward actual changes and look for opportunities to understand the situation, whether it's a baseline for staff assessment, staff development, or a baseline for how our clinics are operating, all of those things tie back to our overall framework. And that evaluation team is responsible for managing that process. We have an assessment team, and we'll talk a little bit more about some of those assessments that team has helped to create and or leverage what is already existing and then only to customize for our use. We have a messaging team and champions, and those are staff members across our various staff roles who are helping us to understand the staff concern, to reflect back staff preferences, and to also be a ready focus group for messaging and other kinds of image and visuals. We have our messaging team that's really taken the lead on trying to understand the best ways to articulate in writing and in other ways the onboarding of this information across our staff experience. Our clinical team policy training, these three teams are obviously taking on issues that really focus in those particular areas. And then lastly, our consumer group, this is a group that we are still really building out, but the goal is that we would have a ready pathway to understand the consumer experience and to gauge them into all of our trauma-focused transformation kind of opportunities. The logic model is very small. You cannot read it at this point, but we have it in here really just to help you understand that we are moving from a sense of understanding what our inputs are all the way to the left of the page, and then moving in a stepwise fashion over a period of 5 years to this moment where we feel like we are closer to this goal of being trauma-informed and that we have realized some of these outcomes in terms of improving our improving our clinical experiences for staff, and that our HR numbers in terms of transition of staff and retention, all of those things are beginning to improve. The assessments that I alluded to earlier, we have a number of various assessments. I'll just say quickly, we have an all-staff assessment. We delivered that as an online survey just to understand staff knowledge, attitudes, interests, and opportunities for improvement. A consumer assessment, which happens in lots of different ways across our various programs, but trying to understand what do we know about our consumers and their experiences and what they're interested in improving. Human resources, where we look for things like retention, absenteeism, other indicators of wellness. And some of those things certainly take place outside of our transformation effort, but we're trying to leverage what is present. The policy team is really developing new policies that make sure that we have appropriate mandates in place in terms of staff development, but then also looking across our various policies so that we're talking about, not just talking about at individual programs, but at the department level, what are our shared expectations for practices. Environmental assessment, we've been to 16 of our 22 facilities and trying to understand what the staff and consumer experience is as they walk in and about the property. And then clinical, trying to understand what the pathway for clinical care feels like for our consumers and our clinicians. This slide is just here to really say that we appreciate that every department, every organization has existing values and primary principles in place before the transformation work will begin, and that we are taking account of our department's other three initiatives, which are health equity, cultural leadership, and deconstructing racist systems, and weaving into those other three pathways the work that we're doing on trauma-informed, so that it does not feel like for staff four separate and distinct change efforts, but in fact that they're all connected. This is just a little bit about where we are with some of our data, just to show that as you get your baseline data, we obviously want to bring that data back into the process of actually then moving forward with shifting the staff competency and shifting the clinical practices. So in this slide, we show where we landed when we initially asked our staff to talk about their understanding of trauma and how it affects their job and the ways that they serve the audiences that come to the health department. Also, we include in our assessment materials our self-care, kind of like a subcluster, because we are also concerned about how staff are taking care of themselves and putting into place some expectations that we're improving even those practices. And then lastly, when we talk about collective impact, we know that because Chicago and maybe some department shift, that is not going to be the end of this change effort. But we really want to talk about how do we encourage and use our space as health department leaders and health sector leaders to encourage other partners across our municipal space to also take up this issue of transformation, and so that we need to be partnering with them at the beginning, so that when we're at the moment where we start talking about new rules and practices, that they're not new to the conversation. And so we are working obviously with Health and Medicine and the Illinois ACE Response Collaborative around issues or to support collaboratives like the Trauma Informed Hospital Collaborative. We've already talked a little bit about health and all policies. This seminar is a part of the Public Health Department statewide effort. And then there are other community-facing trauma-informed transformation efforts as well in Chicago, faith-focused, and then others that are Block Club specific. So I think then I will pause here and allow our next speaker to move forward.
Great. Thanks so much, Marlita, for all that information. We're going to move on now to Winnebago County, and I'm happy to introduce Dr. Sandra Martell. She has been the public health administrator for Winnebago County, Illinois for the past 3 years. She received her BS in nursing from Loyola University of Chicago and her master's and doctoral degrees from the University of Illinois at Chicago, with a concentrated focus on public health. Her dissertation research focused on the impact of home visiting on maternal and child health outcomes. Dr. Martell has spent the majority of her career focused on public health and most recently worked for 27 years at the Cook County Department of Public Health in Illinois, progressing from the position of public health nurse to interim chief operating officer. Dr. Martell has served as adjunct faculty at both Loyola University and University of Illinois, and she has been the recipient of the March of Dimes Perinatal Nurse Recognition and the Cook County Distinguished Service Awards, and has been acknowledged as an emerging public health leader through a fellowship from the National Association of City and County Health Officers and the Robert Wood Johnson Foundation. So I will give you control now so that you can advance your slides. It might just take you a second, and please don't forget to unmute yourself, and we are ready for you when you are ready.
Good afternoon.
Great, we can hear you.
I don't have control yet.
Here, I'll just advance it for you.
Okay. Well, just to give you a little context, Winnebago County is what we call on the state line. We are home to the city of Rockford, which rivals the city of Chicago in terms of some of the social determinants and negative impacts of social determinants. So the first slide kind of gives you kind of an idea of where we are in terms of the 2018 county health rankings. Not something to brag about, right? When you look at this, out of a state rank of 102, the higher the number, the worse the impact. And when we began to look at this, when you start looking at our health outcomes, 85 out of 102, and you start to look at what are the health factors, clinical care, we're in the top third. But when we look at social and economic factors and health behaviors, we're in the bottom third. So really, when we began to do what we call our IPLAN, which you heard about Healthy Chicago 2.0, ours is referred to as Wellness-Focused Winnebago County. I think I need to, yeah. There were 3 priorities identified. We had maternal and child health. If you can advance it, The goal really began to look at that development of the family infrastructure, because similar to Chicago and similar to other major urban areas, in addition we have a rural population, is that we really wanted to support the optimal development of children in all families, especially the families experiencing the negative social determinants of health. We had mental and behavioral health. We're one of the largest counties that does not have a source of local mental health funding. And we recognize the impact that that has had. And so we really wanted to strive to put a community support system framework to prevent, identify, and effectively support managing mental health conditions. And the third was violence prevention. Rockford, Illinois is one of the most violent communities in the nation. And we wanted to decrease the incidence of personal, family, and community violence. Especially in those areas, again, suffering from unequal rates of violent acts. And if you notice, our vision is healthy people and healthy community without health disparities. We suffer significantly from health equity issues and concerns as well. So as each of these groups kind of went through, we organized 3 community advisory groups that began to look at those 3 priorities. They came across, again, an underlying root cause, and you've heard our previous 2 speakers, both Dr. Stiller and Ms. White, speak about the whole impact of the adverse childhood experiences. And so we came to a similar kind of conclusion, was that one of the things that we needed to do in order to impact those 3 health priorities was begin to look at those underlying root cause. So we adopted kind of looking at the trauma-informed approach from SAMHSA with the 6 principles and then the 10 implementation domains. And I always say we don't want to get too. It gave us, though, for us, really a framework. You saw Chicago's framework and how they were addressing it. We adopted the SAMHSA, which said the 6 principles of looking at safety, trustworthy and transparency, peer support, mutual self-help. You can read through collaboration and mutuality, empowerment, voice and choice, and then cultural, historical, and gender issues. And we really felt this approach was significant for our community. Our community has had significant concerns with racism, educational system concerns as it relates to that. And then the 10 implementation domains. We talked about governance and leadership, policy, physical environment, engagement involvement, cross-sector collaboration, the screening, assessment, treatment services, training and workforce development, progress monitoring, quality assurance, financing, and evaluation. So those are the SAMHSA kind of 6 principles and 10 implementation domains that we began to kind of implement. And so we kind of took a look at where are we currently at with those when we looked at the implementation domains. So the first thing was taking a look at governance and leadership. So we reached out really to support for becoming a trauma-informed community. So for us, we looked to both to our elected officials at the Winnebago County Board level and the mayor of the city of Rockford. We also looked at key governmental entities and got them on board. So the health department being one of them, the city of Rockford Department of Human Services, which is kind of serves both the city and the county. And our 17th Judicial Circuit Court became a key, these were the key governmental entities that came on board to say, what we've been doing in terms of, current systems isn't working, and we need to start looking at the impact of ACEs on our health and our community. Then we had some key community organizations that reached out as well. We have what's called the Rockford Regional Health Council. It is one of our community-based organizations. It started out as really kind of the Affordable Care Coalition of Rockford. Our United Way Youth Services Network, which is one of our largest youth serving agencies in the community that deals with our truancy, some of our criminal justice, some of our youth prevention, and children's home and aid. We also felt key partners on this is obviously our public schools. And Rockford and Harlem are our 2 largest public school districts. We're also fortunate to have a partnership in the University of Illinois College of Medicine, University of Illinois Chicago at Rockford, as they call it, and Rockford University. So we had some key both primary and I think looking at our educational support systems as well. So we had good buy-in and governance and leadership at that level when you look at that trauma-informed piece of it. Similar, you'll see the diagram that Marlita also posted. We began to then say, okay, where are our cross-sector collaborations, right? So, as we have the public health agency kind of being the center of this, we also had involvement when we began this process, law enforcement, Rockford Police Department and the Winnebago County Sheriff, which are major law enforcement areas. We also had our 3 health system partners, Swedish American, OSF St. Anthony, and Mercy Health. We also are community health centers, which are the largest provider of care to the Medicaid populations. We have Crusader Community Health, which is one of the largest and longest standing, and a new player in our community has been Aunt Martha's Youth Services, which came out of Cook County as well. I mentioned our school systems before, RPS 205 and Harlem 122. We also had our fire and EMS, Rockford Fire. They were one of the first that was saying they were responding to a great deal of trauma kinds of activities, family violence scenarios with law enforcement in terms of injury in the home. And we had civic groups, oftentimes, Rockford Arts Council. We have an initiative called Transform Rockford, which is a group of collaboratives from both our business and private citizens who really are working to improve the conditions of the Rockford. And we had a community-based organization called the Rockford ACEs Community Collaborative. One of our other participants was our Chamber of Commerce, who kind of, began to recognize, and I think both our, prior presenters kind of talked about the impact, not only on, I think we talked about the kind of outside, but really the business case for this. In terms of what your community, it's not just children that we're dealing with. We're also dealing with adults. They're in our workforces. And if we're going to have stable economics, scenarios, we need to have a workforce that we're able to build resiliency in. Faith-based, some of our largest was Rockford Archdiocese and Second First. Those are some of our largest based. I talked about the elected officials, and then our mental health and substance abuse treatment providers. Rosecrans is one of our largest in remedies, and I don't want anyone to think they're being excluded, but this was to show a representative list. When we call it the jelly bean diagram in public health, we look to see who are our partners in this as we move through this cross-sector collaboration. So the first thing we began to start to take a look of, and you saw the kind of the 5, R's kind of was that kind of creating that awareness. We then ran a trauma-informed summit We started out with Trauma 101 training, so all of our health department staff went through it, including our environmental health, I call it the field inspection staffs. Our Board of Health went through the training as well, and we did a training for the 17th Judicial judges. We brought them in over a lunch and learn and gave them Trauma 101 training. And then from that, we began to build on the Trauma-Informed Care Community Summit, which had collaborative sponsorship. And I often say, in a time when funding and resources are very tight, every group kind of either gave up an in-kind contribution of space or time or markers or pads, as well as some small seed contributions of $500. We had over 150 community participants, and we're a community size of about 300,000. So that's a pretty good size for that. And from that, over 60 signed up to work on the issues. So, it's a little small on the right-hand side, but we really started out with, we had a presenter, Raul Almazar, who came out of the State of Illinois Division of Mental Health, as well as SAMHSA, and he's part of the National Center for Trauma-Informed Care, the NICTIC, if you hear that's referred to. And part of it was he gave kind of an overview, and then what we had was both one of our school districts had begun to implement some trauma-informed approaches and talked anecdotally about their experiences in the field, about what it was like to restructure some of their classroom activities, as well as an individual had been really a victim and had kind of talked about the experiences of it was hard to build through the resiliency and coming to the other side and what that would mean for her. So then our work groups were started based on this kind of small group activity. So from that 60, we began our work groups. So here's where our trauma-informed work groups, and if you map out a little bit to Chicago, we have a collective impact work group. So they are addressing the domains from those 10 implementation from SAMHSA: governance and leadership, progress monitoring, quality assurance, and evaluation. We have a film series group who's going to be the first to kick off this month, addressing domains engagement, involvement. A Handle with Care group that is looking at some of the model practices related to when a child's been exposed the night before there's been a shooting in the family, or they've been at the emergency department all night. Some of the domains that they're addressing are screening, assessment, treatment services, physical environment, and policy. We have a judicial practices work group because, again, one of the challenges we have is when you have high rates of crime and violence, you often have significant incarceration, things like screening, assessment, treatment, physical environment, and policy. And we would be remiss without looking at funding. We feel that this becomes such an important event that an activity that we've got to get all hands on deck. And we're not just talking about funding individual initiatives. It's really about how our community foundations fund programming in the community that incorporating the principles of trauma. How would they fund, various organizations, or how do they align that? Public awareness, policy engagement, involvement, cross-sector, and a training work group that's really looking at policy training and workforce development. So some of the challenges and opportunities we've seen is incorporating the 6 principles. And I think you kind of heard Ms. White really talk about that: empowerment, voice, and choice. I mean, this is really difficult to bring in your consumers and the people that you're designing and working with services on. And really, when you start looking at how do we give that, and as well as cultural, historical, and gender issues. One of the areas that from our workshop, the breakout sessions in the afternoon dealt with, what are you currently doing in your organization? What could you align? Again, not assuming that no one's not doing anything, and one of the areas that we came very short on was this cultural, historical, and gender issues. And how do you get that so that we've got those being incorporated? Addressing the community perception of safety. It's hard to, we've got a group that it's very concerned about public safety. And their idea of public safety is get the crime off the streets, lock them up, throw away the key. And this is not going to happen overnight. So how do you work through that? Recognizing this is a much longer term view. Treatment resources. I think Chicago is one of them, another major city, as well as Rockford and our surrounding areas, where we've really got to look at, do we have adequate treatment resources when we identify trauma that requires trauma-informed counseling and services. You heard about resisting re-traumatization. We want to make sure our systems are really be able to address that. And like every community, I think we always say, we call it the bright, shiny object. What's coming up? What are the competing community issues? Because these are long-range views. The ACEs, and we know those are long-term view. And so we really have to address that upstream, as well as collective impact. We're in a community and an area where really there's competition for resource when there's limited resource. And how do we get everyone to align for a very important to become trauma informed? So we are moving along in our process, and I'm sharing with you, our team has worked through its collective impact group to draft a mission statement, as well as our values, and has worked to identify a logo. So we are kicking off our first in the film series, which is really kind of a community discussion group where they will be facilitated discussion after viewing things like Paper Tigers or some of the more well-known, to begin that conversation at multiple levels. So this is just to give you a little taste of what we are doing in Winnebago County as a health department and why we felt that it really related to the work that we were doing in the health improvement plan. Thank you.
Wow, thanks so much. This was all really great and informative. And I wanted to remind everyone that if you have any questions, please type them into the question box that you see on the side of your screen. We have a couple minutes left. And one question that has come up is for health departments that are just starting out on this journey and on this process, what are one or two things that they should start with, or what are some areas that they should focus on? If each of you want to just share one or two things that you think.
Sure, this is Marlita. I would say that I would prioritize having a team within the department, so bringing together a group that's going to really be the seat for that thoughtful work. I would think that would be very important, and to reach out to other partners so that you could minimize the time you spend building something and probably try to use what's out there already.
And building on the same, I would say that aligning it with your local health improvement plan, because when you look at the impact, whether chronic disease came up or mental health or violence, I think that first of all, getting that alignment, and when you do some of that upstream work, you can see where that begins. And then to Marlita's point, involving the community partners.
And I just want to add one thing, which is I think once you've done both of the things that Marlita and Sandy recommended, I think leading early with that ACE Trauma 101, including the science, so that everybody really has a foundation and a common language from which to do the work is really helpful.
Great, thank you. Well, we are actually just about out of time. So if you have any last questions, please type them in now while I do the wrap up. Whoops. So we will be sending out a follow-up email probably tomorrow. You'll get a recording of this webinar, a link to where you can find more resources from the Illinois ACEs Response Collaborative, and also you will have a link to register for our next webinar on June 20th at 10 a.m., which is the buffering role of community resilience. I want to say thank you so much to our speakers today. This was so great and so informative, and I think that it really helps people get a better sense of what it means to become trauma-informed, how to map out this process, what to think about for the first couple steps as well. And I want to thank you all for joining us today across the state, and please stay tuned for information about future webinars and an in-person training as well that focuses on Trauma 101, which will be coming up at the end of the summer. So please don't hesitate to reach out to me. You can see my email address on the screen, and otherwise stay tuned for an email tomorrow. Thank you all so much. We really appreciate it.
Thank you for the opportunity.
Thanks, Laura.
Thank you.